Hello everyone. In this session, we are going to cover an important topic, that is spread of tumors. So you usually get a long question in your university exams on that. So if you're getting a long question on spread of tumors, you have to write all three ways of spread of tumors, that is lymphatic, hematogenous and transthelomic. Sometimes you get a short question on each of them, so you have to write that portion only. But sometimes you get a long question on the method or the mechanism of the metastasis, in which you have to write all the steps. So we are going to cover everything in this session. So let's start it. The topic, that is spread of tumors, metastasis. Let's start it. First of all, I will let you know the introduction. What do you mean by spread of tumors? Then we will see the various routes of metastasis. Basically, I will be concentrating or telling you there are three routes of metastasis. First is lymphatic, second is hematogenous, and third is transthelomic. In the transthelomic itself, there are three different routes are there. There are three different type of spread in the transthelomic spread. So we will be understanding all three ways. And finally, we will see the mechanism of metastasis, in which I will tell you the 8 steps with the help of the videos. So without wasting any further time, let's start it. Let me tell you the introduction of spread of tumors. What do you mean by spread of tumors? What do you mean by metastasis? What do you mean by metastasis at all? Now, to understand the metastasis, you can see this is a line diagram of a human body. Now, in this human body, let's say this person is having the cancer of any part. Let's say this person is having the cancer of the stomach. So let me draw the stomach here. So you can see I'm trying to draw the stomach. For example, this person can have cancer of any part, tumor in any part of the body. So let's say this person is having the cancer in the stomach, gastric carcinoma. Now, how does it spread in other parts? So, what do you mean by metastasis? So, for example, this is the blood vessel or this is the lymphatic. Some of the tumor cells will loosen from the main tumor and they will enter inside the blood vessel or the lymphatics, and via blood vessel or lymphatics it will spread to multiple other organs, and it will form multiple small secondaries in multiple organs which are discontinuous from the primary tumor. Now in this diagram you can see this one is the primary tumor. This one is the primary tumor, from which some of the tumor cells are dissociating and entering in the blood vessel or lymphatic, and it's spreading into multiple organs. Blood goes everywhere, lymphatic goes everywhere. So via the blood route or the lymphatic route, the tumor cells are spreading in multiple organs. They are extravasating there from the blood vessel and forming multiple masses. These are known as secondaries. So you can see multiple secondaries are there from one primary. The primary is one from which multiple secondaries are arising. And you can see the multiple secondaries which are there throughout the body. They are discontinuous from the primary. Discontinuous word is important and should be highlighted. That is the definition of metastasis. So if the examiner is asking you to define metastasis, how you are going to define? So what is metastasis? It is the spread of the tumor by invasion in such a way that multiple discontinuous, highlight the word discontinuous, multiple discontinuous secondary tumors or secondary masses are formed at the site of the lodgement which are away from the primary. So there is one primary and there are multiple secondaries are formed which are discontinuous from the primary and away from the primary. So they are formed at the site of the lodgement where the tumor cells are lodging. It is the most reliable sign or feature of malignancy. So I hope you have watched my video on benign versus malignant tumor. So there is a video on that. If you have not watched, please watch that. So how to differentiate benign tumor from the malignant tumor? So there are 5 ways to differentiate, but the most important to differentiate is the metastasis. If metastasis is present, it has to be malignant. If it is absent, it has to be benign. So metastasis is the most reliable sign to differentiate the benign tumor from the malignant tumor. Metastasis, the spread of the tumor. Benign tumor do not metastasize. And malignant tumor always metastasize except 2 malignant tumor. All malignant tumor show metastasis except 2. Here, there are 2 exceptions. You have to learn that. What are the 2 exceptions here? Number 1, gliomas of the brain. Gliomas of the CNS. They are malignant. So they should show the metastasis. But till now we didn't found any case of the glioma of the CNS which shows the metastasis. And basal cell carcinoma of the skin. Usually it occurs on the face here and it is known as rodent ulcer. It is also a malignant tumor. So looking at the morphology, they shows the features of the Neoplasia. They are malignant, but they never show metastasis. So what we have learned? We have learned the definition of the metastasis. What is metastasis or the spread of the tumor? Can you tell me? So metastasis or the spread of the tumor, here multiple secondary tumors are formed from the one primary tumor which are discontinuous from the primary, and they are formed at the site of the lodgement. They are away from the primary and they are discontinuous. That is the definition of the metastasis. There are various routes. Now this is the most reliable sign to differentiate the benign tumor from the malignant tumor. benign tumor and malignant tumor. Benign tumor, the metastasis is absent. It never show metastasis. Metastasis is absent always in benign. In malignant, metastasis is always present. All malignant tumor can show metastasis if not treated early. So they always show metastasis except two. You have to learn the two exceptions here. So two exceptions, you have to tell me which are malignant tumor, but they never show metastasis. So can you tell me the name of the two exceptions here? Number one, gliomas of the brain or CNS. They are malignant, but they never show metastasis. Or second is basal cell carcinoma of the skin. Again, they are malignant. Ideally, they should show metastasis, but they never show metastasis. So that is the meaning of the metastasis. That is introduction. We have seen the definition. We have seen it is the most reliable sign to differentiate the benign from the malignant. Benign tumor never show metastasis. Malignant always show metastasis except two. That is the introduction. With this introduction, we have seen the introduction. With this introduction, let me come on the various routes of the metastasis. There are three routes of the metastasis. Okay, what are the three routes of the metastasis? So we have to tell the three routes from which the primary tumor can spread and form the multiple secondaries. What are the three routes? It can spread via lymphatic, it can spread via blood. Blood is hematogenous. And third is transthelomic. Let me explain all three. You can see the three diagrams, human rough diagrams in front of you. So let's say there is again the tumor of the stomach, again the tumor of the stomach, and again here also the tumor of the stomach. Okay, so I'm taking the same primary in all three so that you can understand it well. So for example, here is the tumor, here is the tumor, here is the tumor. How does it spread and form multiple discontinuous secondary in the body? So how? What is the route? So there can be three possible routes. So number one, the tumor cells can enter in the lymphatic. Number two, the tumor cells can enter in the blood vessel. Or number three, it is through transthelomic. Now you can see this is lymphatic. The tumor cells enter in the lymphatic. Some of the tumor cells get loosened and enter in the lymphatic and spread at multiple organs and form the multiple secondaries throughout the body. So this is lymphatic route. It is spreading via lymphatics. You can see this is a lymphatic vessel. Sometimes instead of lymphatic, it is blood vessel. So lymphatic and blood are same. So it is a blood vessel. Instead of lymphatic vessel, it is a blood vessel. The rest is same. So here some of the tumor cells are loosening and entering in the blood vessel and forming multiple secondaries in various organs and showing the metastasis. So this is blood spread or hematogenous spread. So here lymphatic spread, blood spread. And third, transthelomic. In transthelomic, some of the tumor cells are loosened and they don't enter in blood vessels, they don't enter in lymphatic, they are shedded in the cavity. The peritoneal cavity, the pelvic cavity, the abdominal cavity, they freely float here and there. And after freely floating here and there, they involve multiple organs here and there. So this route in which open field is there, and the tumor cells are freely shed in the cavity. This route is known as transthelomic route. Transthelomic route. So the third route in which the tumor cells are spreading via cavities is transthelomic. So the three routes are in front of you. What are the three routes? So you can see this is the primary here, this is the primary here, and this is the primary here. How does this primary spread to multiple organs and form multiple secondaries? So it can be via lymphatics, it can be via blood vessels, or it can be via cavities, that is transthelomic route. So first understand the meaning of the three routes. The same thing is shown to you here in this diagram. You can draw this diagram in your exam, or you can draw this one also. Instead of drawing the complete body, you can show this is the tumor. This is the tumor. From the tumor, some of the cells get loosened and they enter in the blood. They enter in the blood, and via blood, they enter in multiple organs. That you can show this is hematogenous route. Now from this tumor, some of the cell get loosened and they enter in lymphatics. You can see these are the lymphatics. These all are lymphatics. And they spread to various organs via lymphatics. And transthelomic route is not shown here. So you can see. So for example, this is the main tumor and these are the cells of the tumor. So first two routes are more common. Transthelomic is very rare. Okay. Now it can spread via blood. This is a blood vessel. And it can spread via lymphatic. So let me draw a lymphatic vessel. What do you mean by lymphatic vessel? How it is different from the blood vessel? What is blood vessel? What is lymphatic vessel? This is a lymphatic vessel. Now blood vessel is lined by the endothelial lining. You can see these are the endothelial cells. We all know that. The blood vessels are lined by endothelial lining. In the similar way, the lymphatics are also lined by endothelial lining. The only thing is that in the lymphatics, on the way, multiple lymph nodes are coming. You can appreciate these are the lymph nodes. The lymph nodes are coming. In the blood vessel, we don't have lymph node. We have only cavity. We have a lumen with a cavity. Here we have a lumen along with the multiple lymph nodes on the way. These are known as regional lymph nodes. Now imagine the tumor cells getting loosened here and get entered here. And they are traveling here, traveling here, traveling here. And it will spread to multiple organs in the body. Here also it is spreading via here. It is loosening some of the tumor cells and entering in the lymphatic. So whatever lymph nodes are coming on the way, they will get involved. They become metastatic. Whatever lymph nodes are coming on the way, they will get involved one by one. And here also it will spread to multiple organs. So here also it will spread to multiple organs, form multiple secondary. Here also it will spread to multiple organs, form the multiple secondary. But in blood vessel, the lymphatics are not involved. But in lymphatic route, along with the multiple organs are involved. Multiple secondaries are there. But the regional lymph nodes are also involved. Now you have to understand the first lymph node. The first lymph node which is there on the way, which is involved, the first lymph node is known as sentinel lymph node. In lymphatics, the first lymph node is known as sentinel lymph node. So first the sentinel lymph node is involved, then other one by one they are involved. They are involved in a sequence. It is not the thing that first this one will involve, then this one. No, it will be in the sequence, on the way, on the route, one by one. The one which is coming first is involved first. The one which is coming later is involved later. So the first lymph node is known as lymphatic, the sentinel lymph node. So that is the lymphatic spread. So out of the three spread, the first two spread are important: lymphatic spread, hematogenous spread. Transthelomic is also there, but it's rare. So one by one, we will see the details of all three routes one by one. You can get a short question on any of them. And if you're getting a long question, you have to write all with the diagrams. So let's start with the first route, lymphatic route. So okay, before coming on that, these two routes are important now. So which tumor spread by which route? Is it the tumor spread more by lymphatic route or tumor spread more by hematogenous route? So there is a rule. The rule is that carcinoma spread by lymphatic route and the sarcoma spread by hematogenous route. We know there are two types of malignant tumors. The malignant tumors of epithelial origin are carcinomas and the malignant tumors of mesenchymal origin are sarcomas. So the carcinoma spread mostly by lymphatic routes, but exceptions are there. And sarcoma spread mostly by hematogenous route. That you have to learn the general rule. Carcinoma spread by lymphatic route and sarcoma spread by hematogenous or blood route. Make some mnemonic and learn it. So this is the basic rule. Now learn the three routes one by one. We will see the details. So the first one is the lymphatic. I told you regional lymph nodes are involved. Regional. So if there is a breast tumor, you can see this is a breast tumor. Can you see this is the breast tumor? So in the breast tumor, the axillary lymph nodes are involved. Can you see? So it will go and involve the axillary lymph nodes one by one by one. Axillary lymph nodes will be involved. Okay. Now if the tumor is present in the lung, this is a lung tumor. You can see the tumor is in the lung. So in case of lung tumor, the parahilar lymph nodes are involved. The lymph nodes which are present around the trachea and around the hilum, parahilar and paratracheal lymph nodes are involved. So regional lymph nodes are involved. In case of breast tumor, the regional lymph nodes is axillary. In case of lung tumor, the regional lymph nodes is parahilar or paratracheal. So whatever is the regional lymph nodes that is involved. I'm saying it again. For example, this is the tumor, any tumor. Maybe this is a breast tumor, maybe this is a lung tumor. So this is the tumor. Now this tumor, this is the lymphatic for that tumor. So these are the lymph nodes. These are the lymph nodes. So tumor cells will get loosen, enter in the lymph node like this. Some of the tumor cells, the main tumor, primary tumor cells, and they will involve the lymph nodes one by one. They will travel, they will involve the regional lymph nodes one by one. So if this is breast tumor, so all these lymph nodes are axillary lymph nodes. If this is the lung, so all these lymph nodes are parahilar or paratracheal lymph nodes. In any case, the first lymph node is sentinel lymph node. I hope you got it. The first lymph node is known as sentinel lymph node. You will say, ma'am, why sentinel lymph node you are insisting so much and why it is important? For example, there is a lady who is having a breast nodule. She is having a breast mass in her one of the breast. So she is the lady. She is a female, for example. Let's quote an example and let me tell you the importance of sentinel lymph node. And she's coming to me and I'm a doctor and she is complaining, doctor, I'm feeling a mass in my breast, in one of the breast. So what I will do, being a doctor, the first thing I should do is the biopsy. I have done a biopsy of this mass. In the biopsy, I will look for anaplasia. The features of anaplasia are absent. It's a benign tumor. If present, it's a malignant tumor. Unfortunately, I have found on the biopsy the features of anaplasia are present. I mean, it's a malignant tumor. So I inform the lady that it's a malignant tumor. We have to operate it immediately. We have to operate it. We have to take the tumor out. After that, I will give you chemotherapy. We will give you radiotherapy and we will give the targeted therapy, hormonal therapy, all of them. But the first thing we have to operate it. So the lady is convinced and she is ready for the operation. She is ready for the surgery in which we are going to remove this tumor from her body. So what surgery we will perform? You will say, ma'am, either remove the lump only, that is known as lumpectomy, or remove the complete breast if the lump is very big, that is known as mastectomy. So depending, it's the call, depending on the tumor size, whether we perform lumpectomy or mastectomy, that is we are going to remove the primary tumor, okay, with the help of the surgery. But along with that, this is not the only surgery. Will we remove the axillary lymph nodes? Yes or no? This is a bunch of axillary lymph nodes. So yes. So we will give one scar over the breast and remove the tumor. We will give another scar in the axilla and remove the axillary lymph nodes. So why it is necessary to, we always remove the axillary lymph nodes along with the main tumor. Why? Because we know it's a carcinoma. Breast carcinoma is a carcinoma, and carcinoma spread via lymphatics. So if we are removing only the primary tumor and we are not removing the lymphatics, so maybe the primary tumor have already spread it to the lymphatics, and lymphatics are involved, and we are leaving the lymphatics in the body only, and via this lymphatic it will spread to multiple organs. And the same lady, even after surgery, we have removed the primary tumor, even after surgery she will present with mets. So there is no use of the surgery, so we cannot afford that. We cannot put this lady to have the mets in future. So that's why we always give 2 incisions during surgery. So before the surgery only, you have to consult your patient that we are going to give you 2 incisions. The first incision will be on your breast, in which we will remove your primary tumor. We will remove your tumor from the breast, either lumpectomy, mastectomy, whatever, okay. And the second incision we will give in the axilla, and along with your tumor we are going to remove your axillary lymph nodes also. So she may be asking you, I'm having tumor in the breast, so I understood that you are removing my breast, you are removing the tumor of my breast, but why you are removing the axilla? Why? So you have to explain it that this tumor have a tendency to spread via the axillary lymph nodes. So if you remove only your tumor and don't remove your axillary lymph nodes, we are leaving a portion of the tumor in your body, and in future you can present with the mets. We cannot afford that. So we have to remove the axillary lymph nodes. So the next question that can arise in your mind or in this patient's mind is, the axillary lymph nodes are vestigial organ. What if we are removing it? So what side effect or adverse effect can I have after removal of the lymph nodes? What's the function of the lymph nodes? The function of the lymph nodes is to prevent edema, to prevent edema. Now you are removing the lymph nodes. So this lady can present with edema of this hand. The complete hand can have, the corresponding hand of that side can have edema, the lymphoedema after the surgery. Now this lymphoedema is you can say a comorbidity of the surgery. So there are 2 options. If you don't remove the lymph node, she can present with mets in future and she can die. And if you remove it, she can have lymphoedema in future. But we can manage lymphoedema, we cannot manage mets. So out of the 2 options, the lymphoedema is a better version. So you have to consult the lady that in future after the surgery you can have a comorbidity, that is lymphoedema, but we can manage that because it is a benign disease and we can manage that. But if you leave the lymph node, you don't have lymphoedema, but you can have the mets. We cannot afford that. You can die for that, and you can already be entering in the stage 4 cancer. We cannot afford that. Got my point? But having this comorbidity for throughout the life lymphedema is not a good thing. So she may ask you, doctor, is there a way to find during the surgery if my lymph nodes are involved? Then you definitely remove it. But what if my lymph nodes are not involved? Unnecessarily you are removing it, and I will have lymphedema in future as a comorbidity. So can you confirm that my lymph nodes are involved or not involved? You definitely remove my tumor. I don't have any problem in that. The lady is saying, the patient is saying to you, doctor, remove my tumor. Of course, I'm having a tumor in the breast, so you have to remove it. But what about the lymph node? Are you sure the lymph nodes are involved? If involved, you just remove it. But what if they are not involved? Why unnecessarily you are going to remove it? So is there a way during the surgery only can you plan it? Can you decide whether the lymph nodes are involved or not involved? So yes, during the surgery, intraoperatively, we can decide it with the help of a technique known as frozen section. What do you mean by frozen section? Have you heard about it? Frozen section. In frozen section, a pathologist is there during the surgery. So during the surgery, the surgeon take out the first lymph node, sentinel lymph node, and handed over it to the pathologist. The pathologist will make a section out of it and report within 10 minutes, 10 to 15 minutes to the surgeon. And during 10 to 15 minutes, the patient is on hold. The patient is in anesthesia only, the patient is on hold. Within 10 minutes, the pathologist will inform the surgeon whether the sentinel lymph node is involved or not involved. If it is involved, the surgeon is going to continue the surgery and remove all other lymph nodes. Because the first is involved, we consider all are involved. And if the pathologist is saying to surgeon, no, the sentinel lymph node is not involved. If the first is not involved, no one else is involved. So we will leave the patient, we will just suture it, and we will not further remove the lymph nodes. So by doing frozen section, we can take a call during the surgery only that whether we have to remove the lymph nodes or do not remove the lymph nodes. So the main role in the frozen section is of sentinel lymph node. Now, for example, I am the surgeon. So I am operating on this lady. For example, this is the lady and the lady is in anesthesia. And for example, I am the surgeon who is operating on her. Okay, she is having a lesion in her breast, a mass in her breast. Okay, so this is the mass in the breast, you can see. So being a surgeon, I have already operated it. I have taken it out. I have performed the lumpectomy or mastectomy and taken it out with clean margins. Okay. Now I have to take a call. Being a good oncosurgeon, I have to take a call that whether I have to remove the axillary lymph nodes, yes or no. So I'm having a pathologist available with me. The pathologist is capable of doing the frozen section. Okay. So what I will do, I will take the first lymph node out, sentinel lymph node. This is sentinel lymph node, and hand over to the pathologist and ask the pathologist to report it immediately. So the pathologist will take 10 to 15 minutes, and within 10 to 15 minutes, the pathologist is going to inform me that, doctor, either this is involved or this is not involved. If the pathologist is saying it is involved, I will remove all of them. If the pathologist is saying no, it's not involved, I will leave the others. So we are taking a call during the surgery. Now you may be thinking how the surgeon come to know that out of all these lymph nodes, this lymph node is sentinel to hand over to the pathologist. How I will come to know that out of a bunch? So the lymph nodes are in the form of a bunch. Are you understanding? It's a bunch of lymph node. Out of the bunch of the lymph node, how I will come to know that it is the sentinel lymph node, the first lymph node? So we use dye. We will inject the dye in the lymphatics. Can you see here is the lymphatic? So the lymphatic coming out of the breast, I will inject a dye in that. So dye will highlight the lymph node one by one. So the dye highlighting the first lymph node is sentinel lymph node. See, have a look. Let me show you. Here, can you see here? Listen, listen, listen. This is the primary tumor present in the breast. So this is the lymphatic. Some of the tumor cells are coming out of the lymphatic. So this is the first lymph node which is involved. This is sentinel. This is the second tier. This is the third tier. But the first lymph node which is involved is sentinel. I'm interested in that. So can I inject the dye? Listen, see, I'm injecting the dye. Have a look on the video. So you can see this is the primary tumor. This is the primary tumor. Now this is the first lymph node which is involved. And after that others are involved. So the dye is moving to the first lymph node. The dye is moving to the first lymph node. The first lymph node, you can see this is the first lymph node which is involved. After that, multiple others are also involved. So with the help of the dye, we can do that. So I will dissect this one and hand over to the pathologist and ask the pathologist to report whether it is involved or not involved. If it is involved, I'm going to remove all. If it is not involved, I'm not going to remove all. Okay, I will leave all this. So it is only in sequence, they will go one by one. I hope you are getting it. Say yes if you have got it. So that is the thing. Now this is a lymph node. In the diagram of a lymph node, we have a capsule. This is the capsule. And we have the follicles. You know what are the follicles? The lymphocytes are arranged in the form of the follicles. These are the small, small follicles. The lymphocytes are arranged in the form of the follicles. Just below the capsule, we have the sinusoids, the blood capillaries, which are known as sinusoids. Now, just suppose if this lymph node is involved. This is a lymph node. For example, it is involved. This is the first lymph node which is coming in the way. So these are the tumor cells. They are coming in the lymphatics. So in a lymph node, where does they involve? They involve the follicle. They involve the capsule. No, they don't involve the follicle first. They don't involve the cortex. They don't involve the medulla. Just below the capsule, they involve the subcapsular sinus. So the first thing they involve is the subcapsular sinus. What we call it? Subcapsular sinus. So you got it. So in the diagram also, you can see it here. This is the capsule. And just below the capsule, I want to highlight you. This is the capsule. Just below the capsule, please get highlighted the malignant tumor cells. Can you see these are the tumor cells? They are going to the follicles later on. They will go to the cortex and medulla later on. But the first thing is the subcapsular sinus. So in a lymph node, the first thing involved is the subcapsular sinus. You can see the first subcapsular sinus is involved. One more thing you have to learn here is the virtual lymph node. What is virtual lymph node? Now, throughout the body, the lymphatics of head, neck, chest, abdomen, pelvis, lower extremities, they all drain in thoracic duct. Ultimately, the lymphatics of all these places, they will drain in the blood via thoracic duct. And just before the thoracic duct, there is a lymph node that is left supraclavicular lymph node. Can you see? This is the left side. So left supraclavicular, just above the clavicle, you can palpate. This is the clavicle. Just above the clavicle, you can palpate this space, this left supraclavicular space. And in this, there is a lymph node. So just before the thoracic duct, this is the lymph node. So all the drainage throughout the body, the lymphatic drainage want to go in the thoracic duct, but before thoracic duct, they drain in this lymph node. It is known as virtual lymph node. So sometime if there is a malignancy anywhere in the body, anywhere in the abdominal organs like stomach, like pancreas, liver, anywhere is the malignancy, intestine, esophagus or lower limb, and it is coming via lymphatics. And before draining the thoracic drug, the lymphatics are coming in the left supraclavicular lymph node. So this lymph node will get enlarged. Can you see the left supraclavicular lymph node will get enlarged? This is known as virtual lymph node. So sometime patient may come to you that doctor, I'm having a mass over here, no other complaint. So that it is presenting a inside malignancy, hidden malignancy in that patient. Sometimes the malignancy have symptoms later on. It is hidden. Maybe this patient can have a cancer of the stomach, intestine, esophagus, any of the organ, but it is not presenting yet. The patient is presented with the metastasis in the virtual lymph node. So any patient coming to your clinic with a complaint, I'm having a mass in the left supraclavicular lymph node. So always first biopsy that and screen the malignancy in entire body. Do the screening for that. So that is the virtual lymph node. Virtual lymph node is the left supraclavicular lymph node, and it is the lymph node just before the thoracic duct and node, just before the thoracic duct. So sometime it get enlarged. That is virtual lymph node. So we have seen, I'm teaching you metastasis. I'm teaching you the 3 roots of metastasis. 1, 2, 3. 3 roots of metastasis. We have already seen lymphatic route, and now we will continue with the hematogenous route and transthelomic route one by one. In the lymphatics, what important points we have seen? In the lymphatic routes, we have seen that carcinoma spread via lymphatic route. Sarcomas spread via hematogenous route. In the carcinomas, they spread via lymphatic route, so regional lymph nodes are involved. In the breast, the regional lymph nodes are axillary. In the lung, the regional lymph nodes are parahilar, paratracheal likewise. The first lymph node is sentinel lymph node. And sentinel lymph node are important in many surgeries for frozen section. We do the dye, we inject the dye during frozen section, and we take out this first sentinel lymph node and do the frozen section and take a call during the surgery. That is the importance. In a lymph node, the first portion which is involved is subcapsular sinus. Just below the capsule, subcapsular sinus is involved. And there is a term which is known as virtual lymph node. I have explained you that also. What does it mean? So whenever any patient is coming with a virtual lymph node, always screen for the hidden malignancy. Never take it lightly. These are the important points you have to write in your exam regarding the lymphatic route, and you get many MCQs. So summarize lymphatic route. Carcinoma spread via lymphatic route. So via lymphatic route, the regional lymph nodes are involved. The regional lymph nodes are involved, other lymph nodes are not involved. First lymph node is sentinel lymph node, and there is an importance of frozen section of sentinel lymph node via dye, with the help of dye. In a lymph node, is it the cortex or medulla? Which portion is involved? Neither cortex nor medulla. It's the subcapsular sinus which is involved. And what about the virtual lymph node? It is the left supraclavicular lymph node that sometimes it is the only symptom the patient have, and it is present a hidden malignancy. So you have to write all these points in your exam, explaining, drawing well-labeled diagram if the lymphatic spread is coming in your exam. So let's come on the next spread, that is hematogenous spread. Hematogenous spread. So let's come on the next spread. The next spread is the hematogenous spread. I told you, sarcoma spread via hematogenous spread. Carcinoma spread via lymphatic spread. Sarcoma spread via hematogenous spread. Now say this is a tumor. This is the tumor, the primary tumor. And these are the cells of the tumor. Okay, let's say these are the cells of the tumor. Okay, now see, this is a artery supplying pure blood, oxygenated blood to this tumor or this organ. And this is a vein carrying the impure blood, deoxygenated blood away from the organ. Now I'm saying hematogenous route. I'm saying hematogenous route. I mean the blood spread. So the tumor cells are spreading via blood. So my question to you, tumor cells spread via artery or vein? The tumor cell will enter which one? More common. Arteries are involved more common or vein? So here the tumor cells will dissociate. They will loosen and dissociate. Will they enter in the artery and spread in multiple organ, or will they enter in the vein or they spread in multiple organ? Use your common sense and tell me. Have a guess. Have a guess. So can you tell me which one is more commonly involved? Is it artery or vein? So of course the answer is vein, not the artery. Answer is vein. Why? Because vein have thin wall. Vein have thin wall. Arteries have very thick wall. We know that. I guess every student knows that. So when the tumor cells want to penetrate from the main tumor, so what is more easy for the tumor cell? To penetrate the vein which is having thin wall, or to penetrate the artery which is having thick wall? So tumor cells don't penetrate the artery because the resistance is more, because they are having thick wall, but they penetrate the vein more easily. So here, out of the artery and vein, have a look on the thickness of their wall. Have a look on the thickness of the artery The wall of the artery, and have a look on the thickness of the vein, the wall of the vein. You are getting my point? So veins are more commonly involved than arteries because of the thinner walls. They have thinner walls. So that is hematogenous route. That is the hematogenous route in which veins are more commonly involved than arteries because of having thin walls. So first thing you have to learn that. Now listen, where does all veins will go? All veins will go. Do you know all the GIT veins? You know, in the GIT, we have stomach, spleen, pancreas, intestine, other organs, all the GIT organs, the vein of all the GIT organs. Let me show you just a second. The veins of all GIT organs, you can see veins of all GIT organs, they drain in the liver via portal vein. So imagine if someone is having malignancy in any of the GIT, someone is having malignancy in the stomach or malignancy in the spleen, malignancy in the pancreas, malignancy in the esophagus, malignancy in the intestine. So any organ malignancy, someone is having malignancy anywhere in the GIT. So the tumor cells will go in the vein. So here the tumor cells are moving in the veins like this. The tumor cells will go in the veins like this, veins like this. So all the veins of the GIT will go in the portal vein, and via portal vein, the first secondary is formed in the liver. So liver is the most common organ involved in case of sarcomas. So if the primary malignancy is sarcoma, it's spread via blood, it's spread via veins, and veins of GIT drain in the liver. So it is the reason. This is the portal drainage in the liver. That's why liver is the most common organ where secondaries are formed. Secondary can be formed anywhere in the body. Multiple secondaries can be formed. But the most common organ which is involved in secondary is liver. Because liver is getting blood from the venous blood from the entire GIT. So entire GIT organ, they drain in the liver via portal vein. So if there is a malignancy in any of the GIT organ, maybe in the esophagus, maybe stomach, maybe intestine, pancreas, spleen, so it will spread via portal vein to the liver. So liver is the most common and the first organ which is involved in GIT malignancy. So it is for the GIT organs. But what about other organ? Imagine any other organ, not GIT organ, any other organ having malignancy. Any other organ, for example, the brain is having malignancy, the heart is having malignancy, or any other organ, the bones are having malignancy. There are many organs, muscles have malignancy. Any other organ, not GIT organ, have malignancy. So it is spreading, it is a sarcoma, it is spreading via hematogenous route, the blood route. So here the tumor cells will go in the vein. And all the veins of all organs, they drain in SVC, IVC, superior inferior vena cava. So via superior inferior vena cava, the tumor cells will go in the right auricle. From the right auricle, they will go in the right ventricle. From the right ventricle, they will go in pulmonary artery, and they will form the secondary in the lung. So most common organ which is involved in organs other than GIT is the lung. So most common organ which is involved in organs, if there is the primary in the organ other than GIT, so the most common secondary is in the lung. So if there is a primary tumor in the GIT, you tell me where is the secondary. If there is a primary tumor in any other organ than GIT, any other organ than GIT, not GIT, but any other organ than GIT, if there is a primary, then you tell me the most common organ in which the secondary is there. So in case of GIT, the secondaries are most common in the liver. The reason is portal circulation. And in case of any other organ, the secondary is most common in the lung. The reason is caval circulation. This is known as portal circulation because of the portal vein. All the GIT organ drain via portal vein to the liver, and all other organ drain via superior inferior vena cava. It is known as caval circulation. Via caval circulation to the lung. So via caval circulation to right side of the heart, right auricle, right ventricle, and then to the lung. So most common organ which is involved in secondary via blood route is liver followed by lung. Liver followed by lung. So this is the thing which I want to explain you here. Liver due to portal drainage and lung due to caval drainage. This is portal drainage. This is caval drainage. I hope you are getting it. So that is the summary. You got my point? So if there is a primary in GIT, any organ of the GIT, where is the secondary? And if there is a primary in any other organ than GIT, not GIT, any other organ, then where is the secondary? Tell me where is the secondary here and where is the secondary here? Here the secondary is in liver, and here the secondary is in lung. Okay, here the secondary is in the liver because of portal circulation, portal vein, and here the secondary is in the lung because of caval vein, the superior inferior vena cava. So that is the caval vein, and veins are more commonly involved than arteries. And out of the liver and lung, which is more common? If we compare the liver with the lung, so liver is commonly involved than lung. So most commonly organ involved in secondary is liver followed by lung. So this is the complete thing you have to write in the hematogenous route. So till now, out of the 3 routes, 2 are done. We have seen the lymphatic route, we have seen the hematogenous route. Coming on the third and the last route, that is transcoelomic route. In the transcoelomic spread, there are 3 types of spread. One by one, we will see it. Most commonly, it is through cavity. Now see, this is the primary tumor. This is a primary tumor. It is in any of the organ, and these are the cells of the primary tumor. They are not going in the in the lymphatics. They are not spreading via lymphatics. No, no, they are not losing and going to the lymphatics. No, lymphatic spread is not there. They are not going in the blood also. I mean, they are not going in the veins also. So they are not spreading via veins. So neither they are going in the lymphatics nor they are going in the blood vessels. No lymphatic spread, no hematogenous spread. But it is spreading to other organs. You will say, ma'am, how does it spread to other organs? You are saying it is not entering in the lymphatics, it is not entering in the blood. Then how does it spread to multiple other organs? So here tumor cells are shed freely in the cavity. They are shed freely in the cavity, the peritoneal cavity, pelvic cavity, abdominal cavity, and via cavity it spread to multiple organs. So this spread is transthelomic. In the transthelomic, it is through the cavity. It is through the cavity, the natural open field. It is not through lymphatic, not through blood vessels, not artery, not vein, nor lymphatics. It is through the cavities. The best example which I can quote is the female. Let me show you a female. She is a female. It happens in females because, she is a female. And unfortunately, she is having a cancer of the stomach. The cancer of the stomach. I'm just drawing a rough diagram. So let's show you the stomach. So she is having a primary malignancy in the stomach. See, this is the primary malignancy in the stomach. And these are the ovaries of this female, the two ovaries. So here the stomach, the tumor cells of the stomach, they are not going in the lymphatics. They are not going in the blood vessels. They are shed freely in the cavity, the abdominal cavity, and they will float here and there in the cavity. And by floating, they involve both the ovaries. In both the ovaries, there are secondary. So total 3 tumors are there. 1 primary, 2 secondary. You can see 1 primary tumor and 2 secondary tumor. This is known as Krukenberg syndrome. Krukenberg syndrome, the female patient presents with 3 tumors. 1 primary and 2 secondaries. What are the 1 primary? 1 primary, the patient is having a tumor in the stomach, the gastric carcinoma. And the 2 secondaries in both the ovaries, the patient is presenting. So this is known as Krukenberg syndrome because discovered by Krukenberg. So that is the best example in which the tumor is spreading via cavity. It is not through lymphatic, not through blood vessel. It is via cavity, via open cavity. And it is the best example of transthelomic route. It is Krukenberg tumor in which the primary tumor is in stomach and 2 secondaries are in both the ovaries. See, this is stomach. The primary tumor is in the stomach and it is spreading. Here only 1 ovary is shown to you, but it is both the ovaries which are involved. You can see this is both ovaries in this patient. Can you appreciate? This is one of the ovary, this is another ovary, this is uterus. The uterus is very small and both ovaries are enlarged because both the ovaries is having mats inside them because of the primary. The primary is coming from the stomach. So that is the Krukenberg syndrome. That is the first way in transthelomic. In transthelomic, there are 3 routes. The first way is via cavity. The second is via CSF. For example, someone is having a brain tumor or spinal cord tumor. So why either the patient is having the tumor in the meninges of the brain or spinal cord or ependymoma. So tumor cells are shed in the CSF. And via CSF, they move here and there. So for example, the patient is having a tumor over here in the meninges. So tumor cells are shedded into the CSF and via CSF, they carried away to other side and the secondary tumors are formed in anywhere else in the spinal cord, in anywhere else in the central nervous system, brain and spinal cord. You got my point? For example, this is the brain and this is the spinal cord. This is central nervous system. They are surrounded by 3 meninges, we know. So the innermost is the pia meter, the middle one is the arachnoid, and the outermost one is the dura meter. Now the space between the pia meter and arachnoid is known as subarachnoid space and it contains the CSF. So here this is the CSF. For example, we all know subarachnoid space contains the CSF. This is entire CSF flowing entirely in the central nervous system, in the brain and the spinal cord. For example, someone is having a tumor over here. So the tumor cells are shed in the CSF and via CSF they are carried away and they form a secondary or multiple secondary at distant sites. So this is the primary tumor and this is a secondary tumor. Both of them are discontinuous. So spread is via CSF. It is also known as transthelomic route. You got my point? So it is not through the artery. It is not through the vein. It is not through the hematogenous route. It is not through lymphatics. It is not through cavity. It is through CSF. It is through CSF. So it is spreading from one side to another. The same thing is shown to you in this diagram. I guess you got it via CSF. And third is implantation. For example, there is a patient and there is a surgeon who is operating this patient. The surgeon is operating this patient. Got it? Now the patient is having an oral cancer. For example, this is the cancer present in the mouth, in the oral cavity of this patient, and surgeon is operating with the help of a scalpel. The surgeon is cutting the tumor. So this is the blade of the scalpel. This is the blade of the scalpel. The surgeon is cutting the tumor. Now the surgeon is not sterilizing the scalpel, and the scalpel is having tumor cells on that. This is the tumor cells present on the scalpel. Now the same scalpel surgeon is cutting something else. Something else in the body may be required for the surgery. So the surgeon is transmitting the tumor cells via one point to another via scalpel. So tumor cells get implanted here and the secondary will be produced here. So via scalpel of the surgeon, the tumor cells get, it is not through lymphatic, it's transmitted. It is not through CSF. It is not through blood. It is the scalpel of the surgeon which is transmitting the tumor cells from one side to another in the same patient. So it can be implantation. Surgeon scalpels, needles, sutures, sometimes it is like that. But it is rare, very rare. So what we have learned, let me summarize. I taught you the 3 roots of metastasis. I taught you 3 roots. First is lymphatic, second is hematogenous, that is blood, and third is transthelomic, which is further of 3 types. This is what I taught you. Now, if you are getting a long question, write everything. If you are getting a short question, write that portion only. Right, in the lymphatics, what are the important points we have seen? We have seen the carcinomas spread via lymphatic and sarcomas spread via hematogenous, and transthelomic is a rare one. This is the rare root. The first thing we have learned that. Now here the regional lymph nodes are involved. In breast, it's axillary. In the lung, it's parahilar. It's likewise. So regional lymph nodes are involved. The first lymph node is sentinel lymph node. For sentinel lymph node, we inject a dye and take out the sentinel lymph node, and it is required for frozen section so that we can avoid the comorbidity in the patient after the surgery. I have given you the best example in the breast cancer. Okay, we can avoid the lymphoedema while doing so. Okay, and we have learned the concept of this thing also. That is virchow lymph node. What is virchow lymph node? The left supraclavicular lymph node. Sometimes it is the first sign. So write everything about that. Draw the proper diagrams. Coming on hematogenous route, sarcoma spread via hematogenous route. We have already seen that. And here veins are more commonly involved than arteries, because veins have thin wall, arteries have thick wall. Now since veins are involved now, so most common organ involved is liver because of portal circulation, and second most common organ involved is lung because of caval circulation. You can understand portal vein and caval vein. So that is veins are involved. So that is, we have explained why. In GIT malignancies, the liver is the organ which is first metastasis, and in other malignancy apart from GIT, lung is the organ which is showing first metastasis. So that is the thing we have learned. Coming on transthelomic route, here we have discussed 3 routes. The first, through cavity. The best example is Krukenberg. You have to draw the diagram and write down, in which the female have 1 primary tumor in the stomach and 2 secondary tumors in the ovary. The second we have seen via CSF. And the third through the scalpel of a surgeon, that is implantation. So that is the summary. I have summarized them. This is how you have to retain and learn it. Okay, so that is the roots. Now after that, one more thing before ending it, I would like to tell you the mechanism of metastasis. Tell me, I taught you the 3 ways now, the 3 roots: lymphatic, hematogenous, and transthelomic. I want you to learn the steps of the hematogenous route. Tell me the 8 steps. There are 8 steps. I will show you all 8 in one diagram. First see the diagram, then I will show you a video also. In the video also, I will summarize all the 8 steps. Can you see this diagram? In this diagram, first let me help you in understanding the diagram. Can you see this is the primary tumor? Okay, have a look. This is the primary tumor, and these are the cells of the primary tumor. So now the primary tumor want to spread in multiple other organ and form the secondary via blood. You can see this is the blood vessel. The thing which is present between the tumor and the blood vessel is the extracellular matrix. Can you see this is ECM? Extracellular matrix. It is the connecting tissue between the tumor and the blood vessel. So what we have to do, how it will happen, 8 steps are there. There are 4 diagrams, each showing 2 steps. 2, 2, 2, 2. So 2 steps here, 2 here, 2 here, 2 here, total 8 steps. So first the tumor cells, from out of all the tumor cells, the primary tumor cell, this is primary tumor. Out of all of them, some of them become aggressive and they show the heterogeneity. For example, here this tumor cell, a clone of tumor cell, a few tumor cells, they become highly aggressive. They become, because they are going to show the metastasis. Not all tumor cells, the primary tumor cells will do the metastasis. A few of them. So first step, they will become aggressive. A few clone, a little bit clone out of the primary tumor will become highly aggressive. Number 1. After become aggressive, they loosen from the other. So they will become loose. How they will become loose, I will tell you. They will lose from others. So loosening is the second step. They will lose from others. After becoming loosened, so first they become aggressive, then they lose from the others. So all the tumor cells are stick to each other. They are stick to each other like this with the help of E-cadherin. With the help of E-cadherin and complementary adhesive molecules, CAMs. So we have to lose them. So if you want to loosen, for example, I want to loosen this cell from all other cells. So in this cell, I have to do the loss of E-cadherin and loss of CAM. If loss of E-cadherin and loss of CAM is there, so this cell will loosen from the others. Got it? Now this will loosen. Now after that, it will interact. You can see extracellular matrix. So first it will interact with the extracellular matrix. It has already loosened. You can see this cell. Concentrate on the red cells I'm marking. So this is already loosened. Now it is interacting with the ECM, and after that it is degrading. So first it will interact with the ECM and then degrade the ECM and enter inside the ECM. So you can see this the loosened tumor cell is entering inside the ECM. So first a clone of tumor cell become aggressive, then it will loosen, then it will interact with the ECM and degrade and enter and penetrate in the ECM. So interact with the ECM and degrade the ECM. You can see the two things here. Okay, now 4 are done. Okay, now after that, these tumor cells which are loosened, which are aggressive, they have already degraded the ECM, they will enter in the blood vessel. They will enter in one of the lumen of the blood vessel, you can see. But once they will enter in the blood vessel, the lymphocytes, the WBC will kill them because it is foreign particle. So why not WBC kill them? Because they are very smart. The tumor cells cover themselves with RBC and platelet and they form a thrombus so that the WBC cannot identify them. So first they enter in the blood vessel, and after entering, they will cover themselves. They will cover themselves. You can see they are covering themselves with the RBCs and the platelet. They are forming a thrombus so that the WBC cannot identify them. So first they enter in the blood vessel and they cover themselves with RBC and platelet and they form a thrombus. After that they move to some other side. They are moving, and after moving to some other side they extravasate. They come out. Here they were entering. Here they are coming out. Here the entry is there. Here the exit is there. Exit means extravasate to some other side. They are entering here. They are moving here, there, and they are extravasating at some other side. And after that they form a growth, metastasis at some other side. So these are the 8 steps. First imagine, close your eyes and imagine the 8 steps. The first thing, a clone of the primary tumor become highly aggressive. A clone of the primary tumor become highly aggressive. A clone of that. After that it loosen from the other tumor cells. So after loosening, it interact with ECM, and after interacting with ECM it degrade ECM and penetrate inside that. After that it enter in blood vessel and it will form a thrombus inside the blood vessel, otherwise WBC is going to kill him. Okay? So they will form a thrombus. They will move to some other side, they will flow and they will extravasate. They will extravasate at some other side and they will grow and form secondary at some other side. So last step, they will form the secondary. They will form a secondary at some other side. They will form a growth. So these are the 8 steps. Now I will show you a video in which all 8 steps are there. Are you ready to watch the video? Please everyone here. So first thing you can see, this is the primary tumor cell in which a clone become aggressive and loosen. Maybe a clone become aggressive and loosen and it is penetrating into the ECM. Then it is going in the blood vessel. Now it is flowing to somewhere else in the blood vessel. After flowing somewhere else in the blood vessel, it will extravasate. It is extravasating and it is forming a secondary growth. I hope you are getting it. Have a look again. Have a look again. So out of the tumor cell, out of all the tumor cell, a portion of it become aggressive, loosen and penetrating in the ECM. Then that portion enter in the blood vessel. Then they are flowing, forming a thrombus and flowing in the blood vessel far away, far away, far away. At some other far away point, they are extravasating and forming a secondary growth, and that it is doing at multiple portions. So multiple portions have the secondaries. From one primary, multiple secondaries are formed. I hope you are getting all the 8 steps. We will see the detail of all 8 one by one. So the first step, a clone become highly aggressive. So highly aggressive clone is known as tumor heterogeneity. From the population of monoclonal tumor cell, a subpopulation become highly aggressive, and that is known as heterogeneity. So from all the tumor cells, you can see these are all the tumor cells. From all these primary tumor cells, a population, a subpopulation become highly aggressive and is known as heterogeneity. The second step, this highly aggressive clone will loosen from all other. So you can see this is the primary tumor. Tumor cells are adhered with each other with the help of a glue, that is E-cadherin and CAM. So if you want to loosen this from all other, you have to lose E-cadherin and CAM in this cell. If this cell is losing the E-cadherin and losing the CAM, it will get loosened. So these two are like the gum, the glue. You can say the glue is there. So the glue is adhering. If the glue is lost, it will become loosened. Now it can move. It can move. So third step, so you can see the first, this clone become aggressive here and it will become loosened. It become aggressive and it become loosened. Aggressive and loosened. Now it will interact with ECM and penetrate in the ECM. Third step is interaction. How it will interact with the ECM? It is having receptors for ECM. ECM is extracellular matrix. So it is having receptors for laminin, fibronectin, vitronactin, collagen, because ECM is made up of all these. So this is the composition of ECL. So it is having the receptors for all these. So it is interacting, and after that it is degrading the ECM. ECM is made up of collagen, so it is having collagenase. ECM is made up of gelatin, so it is having gelatinase. So basically it is having metalloproteinase enzyme. That metalloproteinase enzyme help to degrade the ECM and penetrate inside that. You see the tumor cells are penetrating in the ECM with the help of enzyme collagenase, gelatinase, metalloproteinase, like that. And after that, you can see it is degrading. See. It is degrading the ECM and entering. Have you seen? It is degrading. After that, it will do the entry of the tumor cell into the blood vessel. Can you see the tumor cells? See this point. The tumor cells are entering in the blood vessel. Tumor cells don't have foot. They are walking and entering. How does they go? So they have a factor which is known as autocrine motility factor, because of which the tumor cells are moving. It is a receptor mediated motility. They don't have foot. It is a receptor mediated motility which diverted towards the blood vessel. You see. So first they are penetrating, degrading the ECM, and after that see the blood vessel. This is the blood vessel and they are moving. This motion is due to autocrine motility factor. And after that they form a thrombus. They cover themselves. The tumor cell cover themselves with the RBC and platelets so that WBC do not attack them. Tumor cell cover themselves with the circulating blood cell so that they form a thrombus. So that the WBC do not do the immune attack on them. They are very smart. So they cover themselves with RBC. So WBC cannot identify them and kill them. Now finally they have formed the thrombus. They move to some other site. At other site they do extravasation. So they are moving to some other site, to other site. You got my point? So they are moving to some other site from the away from the primary site. And at that site it is doing the extravasation. It is coming out. Of the endothelium, it is extravasating out, and after that with the help of the growth factors, it is doing the unlimited uncontrolled mitosis and forming a secondary there. It is forming a secondary. So these are the 8 steps. It is coming out at some other site and growing like anything. So at some other site it is coming out, extravasating, and it is moving, it is growing and forming a secondary mass. So all the 8 steps at the tip of your tongue. Can you enumerate 1, 2, 3, 4, 5, 6, 7, 8? Can you enumerate the 8 steps of metastasis? The first thing, a clone become aggressive. A clone of the primary tumor become highly aggressive, that is known as heterogeneity. After that, it become loosened from other tumor cells by loss of EC adherent and CAM. After that, it interact with ECM because of the receptors like laminin, vimentin, like that. After that, it degrade the ECM because of collagenase, gelatinase, metalloproteinase. After that, it enter the blood vessel with the help of a factor known as autocrine motility factor. After that, it form a thrombus so that WBC cannot identify them. They cover themselves with RBC and platelet. After that, it comes out, it exit, it extravasate at some other site. And after that, it grows there and form the secondary. It forms the secondaries, multiple secondaries. These are the 8 steps. You write down the detail of each of them and you can see all of them here. So here, aggressive, loosening, degradation, and after that entering in the blood vessel. After that, moving to some other site, forming a thrombus, moving some other side. Then they will extravasate and they will grow there and form a bunch of masses. And likewise, multiple secondaries are formed in multiple organs. Okay, so that is how the 8 steps are shown here. Also, we are done. I hope you enjoyed, you learned the spread. So what we have learned, we have seen what do you mean by spread of tumors. It is the most important feature that differentiates the benign from malignant tumor. All benign tumor, none of them show metastasis. All malignant tumor shows metastasis except gliomas of the brain and basal cell carcinoma, that you have to write in the introduction. Now there are 3 routes: lymphatic, hematogenous, and transcelomic. Lymphatic, carcinoma spread via lymphatic. Hematogenous sarcoma spread via hematogenous and transcelomic is rare. Now write down the details here, I have told you the details, and transcelomic have 3 different routes. Now in the mechanism, total 8 steps are there. Write down all 8 and please draw the well-labeled diagram of all 8. I have shown you 4 diagrams. In 4 diagrams, 2 steps in each of them, and you have to draw all of them, total 8 steps. And I have shown you a video also for your better understanding. I hope you got it. You usually get long question. If you're getting long question, write down everything. So you will be able to write down 5-6 pages. But if you're getting short question, either you will get it on lymphatic or hematogenous or transcelomic. So write down that portion only. And sometimes you get a long question on the steps. So first understand your question. What does examiner want from you? So what the examiner is asking, write that portion only. Don't write what you know. Write what is asked. That is the basic funda. Don't forget to have a look on the long question, short question, very short question, and MCQs of this topic given in the notes and the question bank. Thank you so much. Bye-bye.